less than 1.5 rather than those with higher than 1.5. The analysis of gene expression profiles in the endometrial biopsy taken at the HCG trigger day in the general H antagonist recombinant FSH cycle revealed that a marked difference occurred after the level of 1.5. A large meta-analysis conducted in this context over 55,000 cycles concluded that serum starts to affect pregnancy outcome at the level of 0.8. However, the most significant decline in the pregnancy rate occurs more than 1.5. So this meta-analysis also proved that 1.5 is very harmful. In large retrospective study which enrolled more than 10,000 cycles, thresholds 1.5, 1.7, and 2.2 were proposed to predict cycle outcome, and it shows that over 1.5 has a harmful effect too. The next is progesterone to estradiol ratio. There is a retrospective analysis of progesterone elevation and high progesterone estradiol ratio in general H antagonist cycle with day 5 embryo transfer done by Aurora et al. It shows that progesterone elevation did not show any significant impact on implantation rate or clinical pregnancy rate. In contrary, progesterone to estradiol ratio more than 0.5 was associated with clinical pregnancy rates and poorer response to stimulation rates. So, combining progesterone estradiol ratio and progesterone elevation ratio demonstrated that patients with progesterone elevation and high progesterone to estradiol ratio yielded significantly fewer oocytes than group of progesterone elevation only. So combining the progesterone elevation and progesterone and estradiol ratio both together has more predictive effect on the IVF outcomes. The rationale proposed behind the use of progesterone to estradiol ratio is to consider the degree of ovarian responsiveness and to differentiate the sources of progesterone in hyperresponders and poor responders. In hyperresponders, progesterone is expected to be higher levels due to enhanced progesterone production from numerous growing ovarian follicles. But the synchronous increase in estradiol level will accompany it. And the progesterone to estradiol ratio will be counterbalanced. While in poor responders, much progesterone production results from smaller numbers of dysregulated follicles, thus high progesterone to estradiol ratio is expected. The increase of progesterone to estradiol ratio in poor ovarian response could be due to intense stimulation with high FSH doses to overcome the defect in estroidogenesis pathway in poor responders. In addition, the follicular aging process may contribute to increase in the progesterone withdrawal. So, progesterone to estradiol ratio, according to those studies, shows that it is more effective in predicting the effect of premature fertilization on the IVF outcome. The third one is the progesterone to oocyte ratios. Aflatonian et al. Proposed that progesterone to M2 oocyte ratio more than 0.3 as more predictive parameter of identifying the threshold at which the prematurely elevated progesterone starts to be detrimental. Chafiero et al. Have shown that progesterone to follicle index, which is the progesterone to ovarian follicle more than 14 millimeters, as more predictive to clinical pregnancy rate in both agonist and antagonist protocol than progesterone alone. These results are on pair that with the recent retrospective study of Simon et al., which postulated that progesterone to mature oocyte index is negatively correlated with the live birth rate and implantation rate. Moreover, high progesterone to mature oocyte index was associated with poor intracytoplasmic sperm injection outcomes even with high progesterone more than 75 percentile. So, the mechanism of progesterone increase. The role of FSH. It was suggested that enhanced FSH stimulation for achieving a multifollicular growth in ART cycles may be a contributing factor for premature progesterone rise. An in vitro study, FSH has been found to increase expression of 3-beta hydroxystoid dehydrogenase with a resulting stimulated progesterone biosynthesis from the human cortical ovarian samples and the non-euthanized FSH responsiveness human mitotic granulosa cell line, which were used in this study. Thus, estrogen and progesterone production from the stimulated samples increase in dose-dependent manner. The type of FSH, cholephyltropin alpha, it is a long-acting FSH stimulators, has different pharmacokinetics. It is long-acting and gets its peak concentration after 2 days. After it reaches its peak, it starts to decline, but remains above the threshold required for stimulation. A response for 1 week. Thus, it has a high starting dose followed by a step down of serum FSH level, which may relieve the pressure on the stimulated follicles. The idea may provide a strategy to decrease the incidence of premature utilization, but future studies are needed to prove its efficacy. Timing of HCG trigger. It is very crucial to find that optimal timing of administrating the trigger for final oocyte maturation. The oocyte maturity is mostly linked to the follicular size. It was widely accepted that triggering is needed as soon as the size of 3 follicles were more than 17 millimeters. Follicular progesterone production is positively correlated to the follicular size. Therefore, delaying HCG trigger resulted in further growth of ovarian follicles and consequently increased serum progesterone. Serum progesterone increases from 0.8, 0.3 to 1.1 plus or minus 0.5 when HCG was postponed for 1 day. For logistic factors, for example, if the laboratory is not regularly acting, so you are trying to postpone the ovum pickup, consider the progesterone rise if you are deferring the HCG trigger. Type of stimulation protocol. The type of stimulation protocol seems to affect the incidence of prematuralization and its impact on IVF outcome. Many studies show that the long agonist cycles have higher progesterone premature utilization rather than the antagonist cycles, and it was very surprising. But a retrospective analysis by Pacho et al. Included more than 4,000 cycles. Assessment of high incidence of premature utilization in agonist versus antagonist cycles. And the explanation of this, that most of the patients using the long protocol were young patients and they have higher number of follicular growth. So it makes sense that they have higher progesterone level in comparison to the patients with antagonist cycles, most of them recruiting a smaller number of follicles or a fewer number of follicles, so it looks sense that they have lower premature luteinization level. Role of HCG, LH, and recombinant FSH. Some authors suggest that HCG to LH activity may lead to premature rise, and that HCG LH level activity has a protective role against premature luteinization. It was found that using recombinant FSH compared to human minipolar gonadotropins, it shows that patients use recombinant FSH has higher incidence of premature luteinization in comparison to patients with using HMG. Effect of premature luteinization on endometrial receptivity. The first one, 1980, Dr. Colston described the classic histological endometrial dating paradigm for clinically evaluating the luteal phase. Endometrial biopsy is made when there is a difference for more than 2 days between the histological endometrial dating and the actual day of the cycle. It was assumed that super physiological hormone status achieved in controlled ovarian stimulation might impair endometrial receptivity by prematurely elevated progesterone during the follicular phase. Premature utilization causes advancement of the endometrium and could block the essential synchrony between the endometrium and the developing embryos. And this looks the key answer of the effect of prematuralization on the endometrium. It makes the endometrium advanced and it becomes in no synchronization with the embryos. And this is a histological picture of the evaluation of the endometrial dating. Effect of premature utilization on the embryo and oocyte quality. In contrast to the well-established adverse effect of the premature utilization on the endometrial receptivity, the impact of premature utilization on embryo and oocyte quality is debatable. Several reports have proposed that premature utilization does not affect the embryo quality. In line with these studies, large meta-analysis indicated that patients receiving donated oocytes resulted from stimulated cycle complicated by premature utilization, and when they transfer these embryos to the receiving mothers, there was no any adverse effect. So this is large study shows that there is no effect of the premature authorization on the oocyte or the embryo quality, and it does not affect the IVF and ICSI cycles. Premature authorization and live birth rate. Two retrospective studies investigated that impact of premature authorization live birth rate and concluded that premature authorization could reduce significantly live birth rate. Another retrospective study included more than 1,000 IVF cycle, reported that premature authorization was associated with both increase in miscarriage rate and for sure decrease the live birth rate despite equivalent in initial implantation and clinical pregnancy. So it is not only affecting the implantation and clinical pregnancy rate, but it resulted in higher miscarriages and for sure lower live birth rate. So how to prevent? To prevent premature authorization, it is better to use the mild stimulation protocols and step-down protocols. You're performing step-down approach to avoid the intense ovarian stimulation toward the second half of the follicular phase. So take care. The second half of the follicular phase is the most important thing. So if you are starting with a higher dose and decreasing step-down, this is better. Starting with lower dose and ending with lower dose, and this is better too. Therefore, a rise in progesterone level in the follicular phase could be anticipated and prevented by modification of the stimulation protocol. Optimal trigger. The choice of optimal HCG triggering is crucial to prevent further growth of growing follicles, which will result in progressive progesterone elevation. Sonographic detection of more than 3 follicles, more than 17 millimeters, is fair enough to trigger by HCG. Corticosteroids. Progesterone is not performed exclusively by the ovary, but the adrenal gland contributes to 50% of progesterone produced in the follicular phase of natural cycles. Corticosteroid administered can suppress in a dose-dependent fashion the hypothalamic pituitary axis and decreases the adrenal progesterone production. Dexamethasone has been proposed to reduce serum progesterone in the follicular phase of natural cycle. Therefore, corticosteroid administration could be used to decrease the baseline levels of progesterone and subsequently reduce progesterone levels on the day of trigger. Metformin. Gino et al. Proposed that metformin can inhibit the first step of steroidogenesis and consequently decreases progesterone output from the granulosa cell, acute regulatory protein, and 3-beta-hydroxysteroid hydrogenase, which are essential for steroid biosynthesis. Low-dose metformin was found to be useful to improve IVF outcomes in non-PCO repeaters. Mano and Tomai have reported that metformin could be used from the day of ultrasonographic monitoring of stimulation cycle irrespective of patient ovarian reserve to decrease instance of premature luteinization. Therefore, a properly designed randomized controlled trial is needed to confirm the efficacy, and this was recommended by Mano 2014. A group in our Asyut University made this randomized controlled trial, and it is titled The Effect of Metformin in Premature Luteinization and Pregnancy Outcome on Intracytoplasmic Sperm Injection. It was a randomized double-blinded study, and it included 160 patients in each arm. One arm received metformin during the stimulation, and the other arm doesn't receive. And this study suggests the use of metformin in cases with potential premature luteinization in order to improve pregnancy outcome in fresh ICSI cycles by ameliorating the impact of premature luteinization on either endometrial receptivity and or embryo quality. This study should be endorsed by a large randomized trial with more accurate assessment of endometrial receptivity, either by biopsy and oocyte and embryo quality. Rescue strategies. One of the possible strategies to overcome premature luteinization is to delay the embryo transfer to blastocyst stage. Day 5 embryo transfer may provide a good cross-dialogue between developing embryos and the advanced endometrium due to the effect of prematurely elevated progesterone. It is also assumed that endometrium could be significantly recovered from ovulation that have been done by the superphysiological level of steroid hormones. In Shapiro et al. 2010, who was the first one to provide that cryopreservation for 2-pin oocyte has a very good input on the outcome. In line with these studies, more evidence suggests that embryo cryopreservation is the best way to bypass negative impact of elevated progesterone on the live birth rate in fresh ICSI cycles and embryo transfer. So, take-home messages. An obstacle in the study of progesterone luteinization is that authors are not speaking the same language regarding the progesterone cutoff level, measurement methods, days of measurements, and even the terminology. Meanwhile, it is widely accepted that progesterone level more than 1.5 on the final day of oocyte maturation could reduce the pregnancy rate when embryos are freshly transferred. Tailored cutoff levels according to the degree of ovarian responsiveness or the day of embryo transfer were suggested. Various studies have reported different levels of progesterone to estradiol or progesterone to oocyte ratios to be more predictive than use of progesterone alone. The rationale proposed behind these ratios is to consider the degree of ovarian response and to differentiate the sources of progesterone in hyper-responders and poor responders. Progesterone deleterious effect on IVF cycle through causing advancement of endometrium, which blocks the essential synchrony between the endometrium and the developing embryos. This was supported by the differences discovered in the endometrial gene expression profiles between patients having serum progesterone more than 1.5 and those with lower than 1.5. Several measures were demonstrated to reduce the incidence of premature luteinization in IVF cycles. One, addition of corticosteroids to control ovulation patients in patients with high basal progesterone, optimal timing of HCG trigger, aromatase inhibitors, metformin, step-down stimulation approach, and avoidance of enhanced ovarian stimulation toward the late follicular phase. The freeze-all policy with deferring embryo transfer on artificial endometrium is the widely accepted rescue strategy to eliminate hazards of premature luteinization on endometrial receptivity. However, embryo freezing has an extra burden on IVF laboratory, increased IVF costs, and may be complicated by embryo damage during freezing or thawing. Thank you very much for listening.
Thank you, Dr. طارق, for this concise talk. الحقيقة أنا استمتعت بيها وهنأجل معلش الدسكشن للآخر عشان we are running of time. And now we are coming to our next speaker, Professor Dr. Hatem Al-Aujwa. He will talk about dilemma of state uterus, pros and cons of surgical correction.
بسم الله الرحمن الرحيم. The title for today is about the dilemma of managing state uterus, the pros and cons of surgical correction. First of all, I would like to congratulate the organizers of Ganna conference for the great success of their event today, and I hope they more and more success in the upcoming meetings. Also, I would like to thank all my chairpersons and co-speakers in such session. I will take the challenge to announce today for the upcoming year's conference. It will be held in the next year from the 7th to the 9th of February in the Intercontinental Cairo Hotel. I have no conflict of interest to declare. I will start speaking today about the uterine septum. Uterine septum is a very common congenital anomaly, and it may be fibrous or muscular or fibromuscular septum, which divides the uterine cavity into two cavities. This septum in the previous days was managed by open surgery. We call it the open metroplasty, and it was an indication for cesarean section. However, in the last years, it was managed by hysteroscopic excision, and this hysteroscopic metroplasty is not an indication for cesarean section. I think the great problem for managing septate uterus is related to the definition of septum, because there is a great debate in the literature regarding the definition of septate uterus. I will try to summarize such points in the lecture today. There are many societies defining septate uterus going from one definition to the other. It was first by the American Fertility Society, and it was not a clear definition. Then, the HLE-SB classification defines septate uterus as an internal indentation, which is more than 50% of the thickness of the myometrium. And this septum may be dividing the cavity complete or incomplete. Going through the different definition criteria in the literature, the one on the left side is the American Fertility Society from 1988, and then in the midline, the ASRM classification, it was 2016, and they took the cutoff level of 1 centimeters. So, to define a septum, you should have an internal indentation which is at least 1.5 centimeters, which is different than the definition of the Ishri-Esgi, because the one on the left side with the Ishri-Esgi, if the indentation is more than 4 millimeter, it will be defined as a septum. Then, another group which is called the CUMI, on 2018, they defined the septate uterus with an indentation which is more than 10 millimeter or 1 centimeter. And then the ASRM finally in 2021 updated their definition to the cutoff level of 10 centimeters. So 10 millimeter, I mean 1 centimeter. So the final definition of septate uterus, if you have an indentation which is more than 10 millimeter or 1 centimeter. We should have some general principles. Septate uterus has an impact on the clinical pregnancy. It reduces the clinical pregnancy in many of the studies published in the literature. It's associated with increased spontaneous abortion rates, preterm birth and malpresentation, and they found the septate uterus has a very poor impact on the reproductive outcome. The hypothesis behind the impact of septate uterus on the reproductive outcome is not well understood. Patients with septate uterus that we find in our clinics are divided into 3 main important types. Patients with poor reproductive outcome, I mean recurrent abortion, preterm birth, malpresentation, the first group. The second group are patients with infertility, either primary or secondary. And the third group are asymptomatic patients who are diagnosed accidentally in our clinics. And sometimes they have primary dysmenorrhea. So, in such 3 subgroups, we need to have a knowledge about 2 points. What is the impact of septate uterus on such points? This is the first question. The second question, does the surgical improvement as a surgical correction of this septum will improve these points? And what is the impact of septum on IVF outcomes? In order to understand the problem of septate uterus, we should answer for 9 main questions. I will try to go through them fastly in the presentation. The first question, what about the impact of septum on fertility? The second, impact of septum on the reproductive outcomes. And the third is the impact of septum on the IVF outcomes. Then, is there a benefit of surgical correction for all these points? And is there a correlation between the septum characteristics and such outcomes? And what is the best technique for the surgical correction of septate uterus? What is the time interval after I correct the septum? How much time I should wait before allowing the patient to get pregnant? What is the rule of endometrial preparation before incision of the septum? And do we need to use adhesion preventive measures in septum treatment? Really, the answer of such questions is not that easy because it's full of confounders. There are many, many factors which play in the impact of such problems on fertility. I will try to go through the threads of the problem. If we start the problem from the scratch, you will find these points. The first point, what are the baseline characteristics of your patients? Because this will surely affect the result of septum correction. What is the presenting problem? Because patients presenting with infertility are not like patients presenting by preterm birth and abortion. And what is the nature of your patients which are included in your study? Then, what is the method that you use to diagnose septum? Have you diagnosed septum by using ultrasound, or by using histoangiography, or by using MRI, or what? Because these different diagnostic techniques for sure will have an impact on the patient. And then, which criteria? Have you diagnosed your patients by the Eshley-SG classification, or by the QMI, or by the SRM, or what? Because they have different cutoff levels. Patients with septum in the Eshley-SG are not present, are considered normal in the criteria with the SRM. And if these patients are treated by which technique? Is it by cold scissor or is it by resectoscope? Because different techniques for sure will have a different impact on your patients. And have you done a second look hysteroscopy or not after the treatment? These points are the weak points in the studies which are published in the literature, and if you tried to include such points in the new studies, for sure they will be a very strong studies. So we have many players on the ground. I will go fast through these points because it needs more and more time than the time allowed for the lecture. Okay, when we revised the studies present in the literature, you will find three main groups of studies. The largest number of studies are the retrospective studies, which included patients previously operated in the last 10 or 15 years, for example. The problem of these studies is there is a main mismatch between the control group and the study group. Because we found in such studies, they compared patients with a septum with a normal patient, which is not right. And when you want to compare, you should select an ideal control group, which are patients with septum who are not operated, but not patients with not septum. This is the main point of the study. The heterogeneous diagnostic methods, all patients should be diagnosed by the same way. They should be corrected by the same surgical techniques to have the same outcome. Also, we should do the same IVF protocol, because if we use protocols, for sure you will have different outcomes. And this is not due to septum, but due to other factors. The second group of studies, which are before-after studies, they include patients one time with the septum, and when they fail, they do surgical correction, and then they do another trial, and they call it before-after study. This before-after study is not a good statistical way, because it causes a statistical problem, which is overestimation of the effect of intervention. The third study group, which is a very strong one, which is the prospective randomized control trials. It's a very good way, but the main problem for such studies is the difficulty of including your patients. It's very difficult to include a patient in a randomized trial, as we will see later on. Question 1, what is the impact of septum on fertility, and is there a rationale for surgical correction? There is insufficient evidence to conclude that uterine septum is associated with infertility. However, hysteroscopic septum incision is associated with improved clinical pregnancy in women with infertility. But this is the answer of this question. The second one, what is the impact of septum on the reproductive outcomes, and is there a rationale for surgical correction? There is a fair evidence that septum is associated with preterm labor, miscarriage, malpresentation, intrauterine growth restriction, and perinatal mortality. Hysteroscopic septum incision is associated with a reduction in miscarriage rates and improvement in live birth rates. The third question, what is the relation between septum and the IVF outcomes? Hysteroscopic septum excision is beneficial before IVF and embryo transfer in terms of pregnancy, full-term and preterm pregnancy. So if you do incision, you will improve the reproductive outcomes in IVF patients. The fourth question, is there a relation between septum characteristics and such outcomes? If you revise the papers in the literature in the last few years, you will find them speaking about the embryology of septum, because you will find two types of septum, the fibrous septum and the muscular septum. They say that the fibrous septum is mainly due to defect in the reabsorption. However, the muscular septum is there is a defect in the fusion of the two sides of the Mullerian system. Patients with fibrous septum are usually associated with infertility because there is a problem in the endometrium covering the septum. However, patients with a muscular septum are usually having a good fertility potential. However, the patients suffer from preterm labor and abortions. So we can find that the clinical presentation of the patient is related to the underlying structure of the septum. So we have different factors, which are the septum size and width, septum vascularity, overlying endometrium, the uterine motility disorder, gene expression, and protein senses. All these factors play a big role and big important factor in the septum? The answer is, there is insufficient evidence to conclude that obstetric outcomes are different when they compare the different characteristics of the septum. The next question, what is the best technique for surgical correction? We have different techniques. We can excise the septum or incise the septum with using the cold scissor. We can use the resectoscope, unipolar or bipolar, and this can be done ultrasound guided or laparoscopy guided. There is insufficient evidence to say that specific method of these techniques is better than the other. However, when you do septum excision, and this is from the practice, you should have a good mapping of your septum. And this is really done with 3D ultrasound. You should know the size of the septum, you should know the residual myometrium before you start the excision of your septum. Because if you did over-excision, you will have a risk of rupture in subsequent pregnancy. So, avoid excessive septum excision, avoid penetration of the myometrium, take care of the perforation during the procedure, and take care of using over energy because it may induce abortion later on, or rupture uterus. What is the time interval after you did the septum incision? How long time you should wait? We don't have an answer, an evidence for a time, but studies mentioned that 2 months are enough for adequate healing of the myometrium. And so you should wait at least 2 months before you start your IVF trial. Do we need endometrial preparation? Because most of us do this technique in our clinics. We give the progesterone, we give the GnRH agonist before excising the septum. This have an advantage of improving the cavity assessment. You will see the cavity in a better way. But in the other side, this progesterone may affect the healing power after you incise the septum. So it may induce adhesion formation. So there is insufficient evidence against or with using such measures before hysteroscopic septum incision. Do we need adhesion prevention measures after we incise the septum? Most of us give antibiotics, give estrogen therapy, we put intrauterine pallone, sometimes we put an IUD. This method is practically going on, but we don't have an evidence for a benefit of such methods, or even one method is better than the other. In the last say in the couple of years, we have 2 big studies with the Rijking group from Netherlands. They did a big problems with the surgeons doing a job with the septum. The first study was published in 2020 in Human Reproduction, and it was a retrospective study about the septum resection in women with infertility. And they have a conclusion that women with cetate uterus, septum resection does not improve the birth rate or the pregnancy rate or the rate of preterm birth compared with expected management. So they say there is no benefit of septum incision in such patients. However, this study was a retrospective study which is done in 18 centers from 2000 to 2018 in 257 patients. So it's a very long time. It's 18 years of study and of work. The classification system for the septum is changed a lot during such period, and patients were diagnosed by different diagnostic methods, and they were operated by different techniques, and the patients were allocated in a different way, because you find most of patients who were allocated to expectant management, they get pregnant spontaneously. So they are patients with a very minimal septum or not real septum, and they are the good prognosis patients. However, patients who are in the other arm, which is the surgical arm, no one get pregnant. So they have allocation bias, and they directed the patient with the bad prognosis to the surgery, which is a problem. There is no data in such a study regarding the septum size. And then the same group published a very big randomized trial in 2021 in Human Reproduction also. It's a randomized controlled trial, and they reached the same conclusion that septum excision does not improve the reproductive outcomes. However, it was a multi-center RCT. It was done in 10 centers in 8 years, and it was done in 80 patients. So you can see that around 8 years are needed to recruit 80 patients, which refers to the difficulty in recruiting such patients. I mentioned before that to randomize a patient in this way is very difficult. This was called the TRUST trial, and it needs 8 years to enroll the 80 patients. There was no subgroup analysis, and the characteristics of system were not mentioned in such a study. After this publication, a large number of letters to editors were published in Human Reproduction, and they were with or against such study. So, to make the long story short, Mr. Chairman and audience, we can say that up till now, there is no level 1 published evidence about septum resection in women with septate uterus, and no woman was accepted to be included in a randomization study to be operated or not, especially if they have a bad obstetric history. We should not do before-after studies more, because such kind of studies are associated with overestimation of the effect of intervention. Future studies with standardization of the definition of septum, because we should use a single way of defining septate uterus in our patients. Finally, the truth is unknowable, and the information currently available is: if you have a patient with a prior pregnancy loss, or preterm birth, or abortion, or infertility, consider septum incision. And if you have a patient with a septum, but the history is good, the patient was pregnant spontaneously, there is no problem, full-term pregnancy, don't do anything. And if you have a patient which is not tested, the patient is the first pregnancy, there is no prior pregnancy loss, and this is the first trial of IVF, consider counseling of your patients about the benefits and the risks of septum incision in their case. And finally, I thank all of you and also ask our God to forgive Dr. Mahmoud Fathallah, who passed away yesterday, because he presented a lot to all of us. And thanks for you all.
Thank you very much, Dr. Hatem. We are much beyond time. We will stop now and start after break. We will have only 15 minutes as a break after break and start immediately.